So first of all, I want to welcome everyone who's joined the webinar. It's great to see so many students who are participating. We got some faculty who are on board, which is really great. My name is Steve Shapiro. I'm the district's coordinator of experiential learning. And as you can imagine, experiential learning is challenging in a time when we're not allowed to leave our homes, but we are going to try to make an effort to bring opportunities to students for experiences that are virtual. And this will be one of them. This is an opportunity for all of us to think about, I think, one of the really challenging issues of our time, which is the coronavirus has obviously affected all of our lives. We've gone to online school. We've changed the way we're living. We've changed the way we're socializing. We've changed the way we're learning. But really, in the face of this crisis, some of the most interesting conversation is around the folks who are treating patients with coronavirus, folks who are actually having to risk their own safety and their own health in order to deal with a medical crisis that's unlike anything we ever seen before. And so we've set up this conversation today to give you an opportunity to meet a couple of Bexley doctors who are working on treating patients in a couple different settings. And so they happen to be a married couple, although you note that they're social distancing, so they're in different parts of their house. I don't think that's why they're in different parts of their house, but they are. And Michael appears to be in the emergency room. The two guests we have today are Michael and Beth Weinstock. Michael is an emergency room physician, and Beth is a primary care physician. And for today's conversation, what we're going to do is I'm going to begin by inviting them to talk a little bit about how their lives have changed and what their work has been like. But I'm going to invite you to bring your questions and curiosities to the conversation. You all joined this conversation because you're interested and curious, and we want the conversation to be about what you're interested and curious about. So you'll notice the chat bar, and you can see some folks in there. Grant has already posted in there that he's covering this for the Torch. Jacob has got us in there. He was our first guy in there to say, hey, I'm here, this is working. So if anything you hear raises a question for you, or if you came here because you would like to hear the doctor talk about something in particular, go ahead and hit the question in the chat bar, and we'll try to make sure that all of your curiosities get answered. But to start us off, welcome to both of you. And Beth, maybe you can start us out. Tell us a little bit about the kind of medicine you practice and what's changed over the past month for you.
Can you hear me?
Yes.
Yeah, okay. Hi, everybody. My name is Beth Weinstock, and I'm a primary care physician. I went to med school at Ohio State and trained at Riverside Hospital. So at primary care, I basically see anything that walks in the door, but my focus really is on HIV and hepatitis C. And so I see a lot of illnesses related to infectious diseases, and that's what I've been doing for about 20 years. I normally go into the office and I see 14, 15 patients a day, and then I come home. But now I'm trying to do all of my visits by telemedicine. So, but basically I log in, a Zoom contacts to a patient's chart through Epic, which is a big electronic medical record that we have. And then I click, and then I connect with the patient in their home now. So talk about drastic. I mean, I'm used to seeing patients, talking to them, touching patients, and I haven't done that in 2 weeks now. So it's a drastic change. And just as of today, I'm starting to do my virtual visits from home so that we cannot have any physical contact with either other employees or patients in the office. Our office doors are still open, but there's only one provider there who sees walk-in patients per day. So my practice of medicine is really different right now. I'm not sure I like it, but I'm willing to do that, of course, just to prevent spread of the disease.
So Beth, tell us about what is it like seeing patients when you can't, I mean, how do you take vital signs? So much of what happens in medicine is like, you're drawing blood, you're checking blood pressure, all these kind of things. What replaces that?
Well, nothing, which is the challenging thing. Sometimes patients can show me a picture of like a rash, or they can hold up their arm, but I mean, there's limitations, of course. Occasionally people have their own blood pressure cuff at home. I've had patients who get one of those pulse ox machines that they put on their finger, and they tell me how much oxygen they're getting. So sometimes self-reported vital signs. Sorry about the dogs. So I can also, by looking at somebody and talking to them, I can tell how fast they're breathing and how comfortable they are. And so you can take a lot of information in just by watching someone talk to you. That's very helpful when you're assessing someone for COVID-19 and to get a gauge on how short of breath they are. But really, we're very, very limited. I can't listen to someone's lungs. There's some more high-tech models where people can plug into an assessment system through their home computer, and it can measure your pulse, and you can even do an EKG through remote telehealth, but we're not set up for that kind of higher tech stuff just yet.
And so talk about your experience with folks reaching out to you about fear of coronavirus. Or COVID-19? Are you seeing people saying, I think I have it, I don't know if I have it? Tell us about that part of your work.
Yeah, that's actually pretty much all of my work right now. I've done a few visits that are just basic. I want to check in and talk about my medication, particularly with HIV positive patients. But pretty much all of my work now is either talking to people who think they have coronavirus or who I think and they think actually do have it, but they haven't yet been tested. A lot of it is deciding when do people go back to work, how to manage their symptoms at home rather than going to the hospital. And so we are on the phone a lot with people who are worried, rightfully so. And we're talking to people all the time who have asthma and diabetes and heart disease to try to figure out, do you have it? How high of a risk are you? And when do you need to go to the hospital? So that's pretty much the majority of our calls right now. And there's a lot of people who have corona, who are sitting at home sick, really sick, but they're just not going to the hospital or getting tested. So as you know, our denominator on the number of cases it's huge. But we just don't know yet. There are a lot of people who have it and just aren't going to the hospital.
Are many people getting tested? All this conversation about testing, but I don't know if I know anyone who's been tested, but I know people who are sick. Is it like people are just like, well, if you have it, what's the point of getting tested, or where would you get tested? Or by the time we got the results, it would be too late anyway.
Well, yeah, so we have guidelines from all the health departments, both state and local, as well as the big hospital systems to test only a certain subset of people, people who have concerning risk factors or over a certain age, and then healthcare workers. Other than that, we really aren't testing many people, although it's starting to get better where they're loosening that up a little and will test more loosely than they did even a week ago.
So it's interesting. All these numbers we're seeing about the number of cases are probably completely inaccurate numbers based on what you're saying.
Mm-hmm. Right.
And a couple of questions. Maria's asking about precautions when going out for necessities. And the question is, should younger people and families who are less at risk be the ones who go out and get supplies rather than older folks who might have greater risk factors? And that kind of relates to KK's question about how many patients you're seeing that are under 18, or are there symptoms that are different between young people and old people?
So if you live in a family who has a person at risk or who is older, who has, let's say greater than 60 or has heart disease, diabetes, or other immune suppressing conditions, then they shouldn't, if possible, be the one going to the grocery store. In that family, I would pick one person who always goes and goes by themselves. And then that person is very diligent about washing and protecting from bringing home any COVID to the family. So let me read that question again. Yeah, so I think it should be the younger, healthier person who wouldn't be, statistically at least, that ill if they did get COVID, and then they have to be very careful not to bring it home to the family. And I don't see patients under 18 anymore. I did for 20 years, so I'm trained to see pediatrics, but in my current job, I don't see people under 18. It does seem like their symptoms are a little bit different, and thankfully not as severe as other people. But kids who are under 18 have been hospitalized, and some have gotten very ill, but it's pretty rare.
Yeah, one of the things that's been interesting to me is seeing these comments. Like Dr. Fauci yesterday said that perhaps 25 to 50% of people who contract the virus never develop any symptoms, which makes me wonder how many folks actually have contracted the virus but never experience health complications. That is, they could pass the virus on, but they're not having any health complications from that. And I don't know if that's something we even know because we can't really track and we're not testing widely.
Right. I mean, the greatest public health measure we could do right now would be to both universally test, which isn't even feasible at this point. But if we did universally test and then, you know, we're able to isolate pockets of the disease in asymptomatic individuals and isolate them, then we could get rid of this thing pretty quickly. But we don't have that testing capacity or public health workforce yet.
Danny's curious about the tests. A lot of people aren't getting tested, but she's seen images of the test. I'm guessing Danny's seen the people sticking things far up your nose, and it doesn't look very pleasant. What can you tell us about what the testing process is like?
It is a cotton swab up your nose. I wouldn't say it's fun, but it's not painful, and it's not dangerous. It's really just feels bizarre. You know, you have something farther up your nose than you would want it to be. And it's not painful. It just gives you that gaggy feeling, but it's over pretty quickly.
Yeah, Jay's asking a question I think is kind of out there. What's stopping people from getting tested? Do you think people are afraid of getting tested? Is it just that testing, we don't have a regimen set up?
No, I don't think it's people are afraid of getting tested. I think it's more the triage system in place prevents everyone from getting tested. So if you were to go over to the drive-up testing at Ohio State at their location, the person meeting you at the car would triage you based on your risk factors as well as your symptoms. And they might say,
these folks don't know what triage is. Explain what that is.
Oh, triage is just where an individual trained in healthcare, could be a nurse, could be a doctor, asks you a lot of questions based on an algorithm, meaning, do you have a fever? And if you have a fever, do you have a cough? And then do you have a known exposure to coronavirus? And then it would go down the tree. And if you met all of the certain criteria, then they would go ahead and test you at that moment. But there are people who go there, they're like, well, you don't need to be tested. You can go home, and they give you advice on supportive care and how to recover from the virus, but they don't test everybody. So it's not a matter of fear or people not showing up or asking. I just think that there are a limited number of tests, and they're just rationing supplies.
Yeah, yeah. And so Maria's curious about what you could say about treating the viruses. Are the cures in progress? What do you think that might look like? Vaccinations. I know that the timelines that you hear on those are never short.
Michael, do you want to answer that one? I feel like you're getting bored.
Oh, Mike, you're muted. Let's get you.
I'm just loving not being the center of it. So no, I've been enjoying it so far. So as far as a cure, you got to think that we've had the flu for the last 50 or 100 or whatever number of years, and there's no cure for the flu. And even something like Tamiflu is minimally helpful, maybe shortened duration of symptoms by like 12 to 24 hours, but doesn't help to decrease deaths at all. So as far as an actual cure for the actual virus, it seems unlikely. But the interesting part about this virus, and we're still trying to understand more and more of it, but it's not just the fact that the virus injures you, but it's also your body's response to the virus that in a lot of ways impacts the symptoms that you have from it. So for example, you can get the virus and you have some symptoms, which could be a dry cough or a fever or chest pain or shortness of breath, headache, sometimes abdominal pain, sometimes even GI symptoms like vomiting or diarrhea. However, everybody responds to that differently. So just sort of harking back a little bit to that study or that statement that Fauci made about the 25 to 50%, that came from a study from Iceland. They looked at 17,900 patients. They tested 5% of their population. And when they tested them, they found that of the people that were positive, between 25 and 50% had no symptoms at all. So just the first point to the listeners here, being younger people, of course, is that this whole social distancing thing, even though it seems a little bit sort of crazy and it's sunny and it's springtime and it's so nice here in Bexley, that's super important, especially for younger people who might not demonstrate symptoms, but can absolutely take this virus back to their parents, to their grandparents. And those people can have even more symptoms. But there are young people and even children who have died from COVID. So just because you're young doesn't mean that you're completely protected. You're less likely to have a problem than older people, but not completely protected from it. But as far as the actual way the virus affects the body, just finishing up here real briefly, is that the virus affects us, of course, causing damage to our body, but possibly, or most likely, some of the way the body responds actually causes even more damage. So this thing called a cytokine storm. So where our immune system reacts in such a way that it causes a lot of inflammation and damage, causing what you've probably heard about on the news, this ARDS, the respiratory distress syndrome in your lungs, where you get scarring, which is pretty much irreversible. Well, some of those things are damaging too. So as far as the answer to the therapy question, there are a lot of things that are being looked at. But at this time, hydroxychloroquine, chloroquine, ivermectin, there's some HIV drugs that are being looked at. None of those things have made any significant impact. And there's been actually some pretty good studies with some of them. Other ones are just getting started. Other ones we're getting some initial results, but we haven't found anything in any way, shape, or form that's a cure for the virus. As far as the vaccine, that's something that is still probably a long way off.
Well, Mike has got us pretty far down at science road. I'm going to pull back and I'm going to hold off on questions for a sec. Mike, why don't you tell us a little bit about your work? You work in the emergency room. Give us a little sense of like where you work and how things have changed in the emergency room over the past month, and then we'll get to some of the questions that have lined up.
Yeah, so I am an emergency physician. I had worked for 21 years at Mount Carmel St. Anne's here in Columbus and Westerville, and just 3 years ago I switched down and I'm the associate program director at the emergency medicine residency at Adena. So really working in the ED and also teaching. So the emergency department is probably one of the scarier places now. And so in 25 years as an emergency physician, I calculated the other day, I've seen over 100,000 patients in my career, but I've never until the last month been concerned for myself or bringing an illness back to my family the way that I have been over the last month. And to say honestly, it's a scary proposition thinking about it, because it's a silent, in some ways, it's an invisible killer, and it's almost impossible to completely avoid what we call cross-contamination. In other words, when you see a patient who has respiratory symptoms, avoid bringing that back to your desk when you're doing documentation, seeing other patients. We try as hard as we can with N95 masks and a lot of other different ways that we do. But in regard to the specific question, the practice of emergency medicine has changed in the last month, and it'll probably change back at some point, but we're seeing fewer patients because a lot of people are scared to come to the emergency department, but over half the patients that I'm seeing are ones that are coming in by the paramedics, and they're really, really sick patients. So I'm seeing fewer patients, but much, much sicker patients, some with respiratory symptoms, but also other ones with strokes who delayed their care because they were concerned about coming in, and other types of illnesses. So it's an interesting, but also scary time to be practicing emergency medicine.
I just want to make a side point before we get back to your thing, which is interesting. We talk about the number of deaths related to COVID-19, but the truth is there may be other deaths that are not directly related, like someone who has a acute medical condition who chooses not to go to the ER because they're afraid of getting coronavirus, and then they get sicker and die because of that. So there's this kind of secondary. But Mike, tell me about like when you go to the ER, like, or when you knew this was coming, like, was there a party that thought, maybe I'll take some time off for a while, or like, I mean, you're putting yourself at risk. You're asking these questions about like, am I going to get contaminated? Am I going to bring that home? Am I going to infect my kids? Or, I mean, what was that emotionally like for you to confront that?
Well, mostly it was tough because, honestly, I'm not volunteering and asking for extra shifts. However, if I was asked to do that, I would certainly say yes. We have some physicians who are, older and who have some other medical problems. And I know one of them in our emergency department is retiring at the end of the month. They probably should be retiring now, actually. But because of the fact that this is so dangerous to them, the process specifically, I drive to work, I walk in, they check my temperature with a thermometer that goes across my forehead. I get a special sticker saying that I've been cleared to enter the area. And then the entire time that I'm there, I have a mask on. We're extremely careful with hand washing, with trying to avoid that cross-contamination. As far as the personal basis. I don't take my computer there, so I'm not actually working with that. A lot of people are putting their cell phones in plastic bags so they avoid getting germs on their cell phones. We're keeping a 6-foot distance from each other. And even when this started, I had patients who were coming. Like there was a father of a child that was there, and he was like getting closer to me. I was like backing up. He was getting closer. I'm like, hey, listen, just want to try to be true to the recommendations and stay 6 feet away. And he's like, oh, okay, I'm so sorry. I completely understand. But there was an interesting story. Just the last shift that I worked a few days ago, there was a patient who had been to a different emergency department, and he had vertigo. He had spinning, and he was a manual laborer. He was on some sort of crane type of thing. When he got off it, he got this sudden onset of this room spinning. This spinning sensation that he had. And so he had to sort of steady himself against that. After a little bit of time, he went to the emergency department. They did a CAT scan of his brain and some different labs that all came back negative. They sent him home. My guess is they probably would have done more testing, except for the fact we're trying to get people in and out pretty quickly. He came in to see me then 24 hours later. And then at that point, not only did he have the room spinning feeling, but he also had some pain inside of his neck. And so my thought was, well, this could be some sort of inner ear problem. That's something that's not as concerning. However, I was more concerned, well, maybe he has a stroke in the back part of his brain in the cerebellum region, which actually controls the balance center. Maybe that's what causes vertigo. So I was curious about that and concerned about that. And so I got a different type of CAT scan where you use contrast, but not only of the head, but also of the neck. And it actually did turn out that he had a dissection, so a splitting apart of the artery, the vertebral artery in the back of his neck with a clot in that location. And because that decreased blood flow to that part of his brain, the cerebellum part, which actually caused that stroke. And so obviously got admitted for that. But the initial visit that he had, I'm guessing was probably done a little more of a cursory way because of concern about COVID, trying to get him in and get him out, do the most minimal amount of testing possible. Unfortunately, with this patient, didn't really serve him because he turned out to have a super serious process and probably is going to have permanent disability as a result of it.
Let me ask you, when I go to the grocery store, and I mean, I'm a pretty low-key guy, but when I go to the grocery store, I can feel like my heart rate go up. I can feel like, I just feel stressed. And I wonder, when you get to the hospital and you go, I mean, as you go in, do you have like, are you just like, I'm going to work, I'm focused, or do you have like symptoms or reactions, stress reaction?
Yeah, after 25 years, I've completely depleted my body of all adrenaline. So even when I'm leaning back in a chair and almost fall over, I still don't even get adrenaline with that situation. It's like completely gone from me. So no, I don't have that when I'm walking in the emergency department. Maybe I should have more of it, and maybe it'd be good if I had it. But the fact is that it's transmitted in the same way that we have tried to decrease transmission from the flu and from colds and that kind of stuff. I mean, it's obviously completely different than that, but we try to decrease transmissions of those things when we've seen patients with those situations. So by using what are called universal precautions, where we try to make sure there's no body fluids of a patient that comes in contact with us, or aerosolized droplets come in contact with us. We have patients with tuberculosis, and it's a fairly analogous situation. We've converted all our rooms in the emergency department to what's called negative airflow. So air is being sucked in. It's like having giant fans in every room. I mean, it's silent, but where all the air is actually being sucked out of the room at the present time. So hopefully that decreases transmission. So I don't have that specific concern myself. Again, maybe I should. And also when I go to the grocery store, if I'm away from people, the risk of transmission in those situations is pretty minimal. Obviously in the ER, it's much higher. But yeah, short answer, I probably should have more, but I really don't.
Okay. Beth, let me bring you back to KK. Her question about her mom sewing masks out of fabric, and is that a viable way to protect oneself in a public space? This question of our masks protecting ourselves, protecting others.
So the mask could play an important role, but it's more to protect you from giving it to someone else. The mask itself, especially homemade masks, don't really have a good enough seal around the edges to protect you, and also don't have a filter, but not enough to protect you from getting the virus. So the move to have people wear masks in public is more so to protect us from passing the virus. There is a little, well, I shouldn't say little, but there is evidence that the mask would prevent respiratory droplets from leaving your mouth and landing on someone else. But if you were next to someone, say, who was coughing or sneezing, that mask probably is not enough to prevent you from getting the virus.
And so it's not
Does
just
that make
because of
sense?
the fabric, it's because of the seal. It's not stuff can still make its way in.
Yeah, and also with the medical masks, the N95 OSHA approved mask, they have a filter near the breathing apparatus, and the filter has such small space between the elements that it's able to catch virus particles as they head inward as you inhale. So our homemade masks or the basic blue surgical masks don't do that, but they do catch virus that might be leaving our mouths if we were to cough or sneeze. So they play a great role, but it doesn't really protect you from catching the disease.
Interesting. We have a couple of questions from Ruby and Alex. Ruby's asking how long it takes to get results back from a test. I know one of the initial concerns was it was like you could, even if you got a test, it was taking 5 to 7 days to get the test results back, at which point it almost seemed like, yeah, well, we're pretty far down the road. Has that changed?
Well, two things have changed. One is that several organizations have created a rapid test, which we'll probably see in use much more commonly as we move forward, and that's within 15 minutes. There's some limitations on that test because you only use it one machine per person at a time. So you can imagine the machine's running for 15 minutes and you've got a line of 100 people. This test is going to take a while, whereas the current tests we're using, they throw, I don't know how many, but multiple tests into the machine at one time and have it run there. So you get mass results relative to the rapid 15-minute test. So there's that. But the backlog is not necessarily that the test needs to run for 5 to 7 days. It's more a backlog of the volume that the labs are getting and how fast they can run them. It's ramping up. So right now I'm hearing 4 to 5 days to get tests back, but maybe that's changed actually in the last week because we are seeing a replenishment of supplies in the last week.
Great. And I don't know if either of you want to respond to Alex's question about, is this going to be a recurring virus like the flu, or after a while it'll be gone and we won't see it again? Will it come back? I've read some articles that have dealt with this question of we're in this quarantine, but maybe we'll come out of quarantine and then we'll have another uptick and we'll have to go back into our homes. And I mean, how do each of you see this playing out? How does this end if it ends?
Well, my thought is, I don't think it's going anywhere. I mean, based on how widespread it is at this point, I don't think it's going anywhere. I think that what we're going to do is get an immunization. I don't think that's a hard thing to do. I just think it takes some time. So we're going to get an immunization. My prediction is that we'll probably get an annual immunization to this, like influenza. That's my prediction. But even if we don't do it annually, what I hope to see is that we have such a ramping up of resources, both with workforce and testing, that when it starts to rear its head again, that there's an immediate, rapid response to it, so that we find pockets of the virus. And once we find it, we will, isolate or hopefully treat if we have something to treat it with, and tamp it down. And once a virus loses all of its vectors, that virus over time does tend to die out. I mean, or become less powerful. So if we could both get the immunization and also get a greater public health response to outbreaks, I think we're going to be fine. It just, we weren't ready for this.
Mike, where do you see it going?
So I just actually this morning listened to a almost 2-hour podcast on fast speed, actually, from Los Angeles. And they had an epidemiologist who was just awesome and really showed in a lot better way than I've seen anyone do it. With the flattening of the curve, we decrease the number of people have it, and then obviously decrease any even like short-term immunity with it. I see it just like Beth is saying. I see it sticking around. I see us hopefully having a vaccine and having vaccination against different type of subgroups against it each year. But I also see a recurrence of this once we sort of hopefully get it under better control. Maybe we end our at least extreme social distancing or self-quarantine sometime, hopefully, maybe towards the end of May or in June. Yeah, maybe we start going out to restaurants again and we start having a little bit more normal lives. I could see, for example, a football season in the fall where the 15-minute test is done on all the players, so we know that they don't have it, and people sit every third or fourth seat apart from each other, and you know, you start getting to the game 2 hours early. So there's going to be some changes in our lives. But you know, when you think of any war that we've been at, and you think of World War I or World War II, Vietnam, I mean, there's so many different things. You know, it's a different type of struggle, but it's but compared to those sort of things, and I love, and I've repeated this statement so many times, you know, this thing that's went around Facebook, but, you know, it said like, you know, our grandparents were called off to war. We're being called to sit on our couches. It's not that hard. We can do it. And so I see this as coming back. I see it as not returning to the same way that we'd been before, but it's still going to be a good life. It's still going to be a fantastic life. It's still going to be able to share experiences with our friends and our loved ones and our grandparents and all these other folks. It's just going to be something that we're going to have to be aware of, and there'll be some changes because of it. And, you know, that's with everything, as humans continue to try to figure out how to put 6 or so billion people on this small planet. There's going to be more changes that we're going to have to face in the future, global warming and other things too. So maybe we can preemptively try to think of what other type of problems could come about and take some measures to make sure that when it does come in the future, we're more prepared to deal with it than we were this time.
Mike, your optimism is one of the many things I appreciate about you. On that scope, Ruby's asking about how long for a vaccine. Is this like a 12-month, 18-month, 6-month? What do you best guess?
For the vaccine?
I think, I think they're pushing it. A normal vaccine might take 18 months. It's not going to take that long. They're pushing it through quickly. There's an exciting study out of the University of Pittsburgh about a vaccine that they've already gotten approval to move to the next stage very quickly. I mean, if I had to predict the way we're pushing this, I would guess 8 months. And I'm not a vaccine researcher, but just based on history, I would say that they're pushing this fast. I would say we'll see a lot of movement on this at least by winter.
Yeah, it's one of the questions. Caroline asked a question a little earlier about when you two decided to become doctors. Did you ever imagine facing something like this during the span of your career? I was just reading an article about the 1918 influenza outbreak, and it was from the LA Times. Did some research back into their archives, and you know, a lot of the same stuff, social distancing and people not, you know, like, but it's been a long time. And, you know, I think it's easy for us to get into the mindset of like, oh, pandemics were something that happened in the past, or pandemics were something that happened in other countries. How did either of you see this as like, yeah, this is something that's real and it's going to happen in our lifetime? Or were you also kind of lulled into that, like, well, probably not something we need to worry about?
Well, so no, I didn't anticipate this ever. I mean, I decided to go to medical school when I was 20, and I wasn't thinking about the future in a big way at that point. But I tell you what really hit home for me for many years was the HIV pandemic. And I felt like I was in training during the height of that and saw lots of patients die from a virus. And so I had it in my mind through my entire career of how devastating a new virus can be, you know, because we'd never seen HIV before, and how long it came and killed thousands in a very short period of time. So I had it, I think, in my psyche that this is something that could happen and happen unexpectedly. So I didn't predict this though. And the funny thing about HIV, which I shouldn't say funny, the unfortunate thing is that so many people during that time period were able to say, oh, that's not something that happens to me. That's a virus, it's scary, it's killing people, but that's over there. It's not going to touch me. And I thought that was and I was in my 20s at the time, I remember thinking that's such a dangerous way to think when it comes to a virus. And now we can see viruses don't care. They affect everybody, age, sexual orientation, money, I mean, everything. The virus doesn't care. So the answer is yes and no, I guess, to that question.
Yeah, Mike,
Yeah,
go
I
ahead.
was going to say, I hadn't really ever thought of my own safety. The universal precaution thing, sticking yourself with a needle, workplace violence. I mean, all those things seem very removed and esoteric if you're cautious. So, no, that wasn't ever anything I ever thought about as far as a risk to myself.
Yeah, it's been for me, a new way of thinking about, like, it's interesting. This virus has given me a new appreciation for folks in the military. and the reason is because I have a lot of friends who work in medical fields, and I see them exposing themselves to danger, and like they're doing that as part of their job, and it's a risk they have to take. And I think about folks who sign up for the military who are basically saying, I'm willing to put myself in front of, like, bullets and bombs, landmines and whatever. And it's interesting to think, like, there are people right now, medical workers are in this position, but there are people whose lives, people who are firefighters, people who are law enforcement. There are a lot of people who expose themselves to this kind of risk as part of their job all the time. And it's an interesting shift that now healthcare workers are experiencing some of that same thing.
Yeah, that's, people that are serving our country and really literally putting themselves into, second by second harm's way. I would never equate myself with that. Being on the front lines of the ER sounds sort of cool to say, I guess, but it's risky, but it's honestly not really like that specific second by second sort of risk where someone's actually shooting at you. The weird part about it, though, is that it's an unseen enemy. So even though we know it's there, there's some thought that those aerosolized droplets can enter your body through your eyes, just for example. So, if obviously it can enter through your nose, through breathing, if you touch something and the touch of your mouth or your nose. So even if you're super, super, super cautious, when you have an emergent procedure, like if you're putting a breathing tube in someone, if you're intubating them, well, in that situation, you could get it. And so we have some things that we're doing with certain boxes that we're putting on our patients. We have different ways that we're trying to decrease some of those aerosolized droplets, but nothing is completely protective. And even in Italy, some of that information is that of all the people that caught this, 14% of those were healthcare workers. And that's a really, really frightening statistic, especially when you think about primarily bringing that home to your family. And then also, of course, if you think about that to yourself. So I, in a full disclosure way, I have thought about more than I ever have in my life, my own mortality in the last month. And it's pretty crazy. There was an emergency physician who died just 5 or 6 days ago in New York City. And he was, a little bit older, but certainly 55-year-olds, that's how old I am, are catching this. I mean, Boris Johnson in, England, I mean, in London, I mean, he's the prime minister, and that's how old he is 55, and he's in the ICU with us right now. And he obviously wasn't working in the medical field, but when you think about, the folks who are totally fine and, going for a jog and hanging out with friends, and then they work a shift and in 5 to 7 days get symptoms, and then a week later or 5 days later in the ICU and get put on a ventilator, and then that's the end. I mean, it's a crazy thing. Even though it's not getting shot by a bullet, still it can be within 10 to 14 days. You can go from being totally well to obviously being dead. I mean, it's a super scary proposition.
Yeah. Mary Beth raises an interesting point, which is she's talking about doing undergraduate research on AIDS and the recognition that a lot of HIV positive individuals and others who were in affected communities were continuing to engage in unprotected sex or weren't telling their partners. And there wasn't always the kind of seriousness, even in something that was that direct. And I wonder how you think about that in terms of today. Like, do you think from a public health standpoint, how are we doing at taking this seriously? Are you out in the world seeing people doing things that you're like, oh, I'm worried that people are allowing things to go on, or even political responses that are concerning to you?
Well, I think I've seen I've seen a lot of people not take it as seriously as they should. I've seen that personally, just at a store or at a park or wherever you happen to be, and you get worried. You want to just like pull people apart and say, you know, don't stand that close or break up your group. But I also, unfortunately, some of the alarm level has taken such a political divide in some ways. And I find that a lot of the rhetoric on the news or in the reports I read obsessively every day, it seems like a lot of people are sort of taking a stance of lack of concern, sort of based on a political view. And I tell you, the last thing you need to do with a virus is just to start talking politics, because again, the virus doesn't care. And so if one were to say, oh, I'm not worried about this is all a hoax, or this is overblown, based on perhaps what a political stance, where it leads you, I think that's so dangerous. So, you know, I've seen that, and I've seen a lot of people talk like that. And then there's, you know, people who are so nonchalant. I mean, I haven't seen this, but you hear about like Corona parties people are having, and then the whole spring break thing, which is so unfortunate. The thing that happens, for example, if you live in a borough of Manhattan or outside of Manhattan, and you have to get into the city to work, to feed your family, and you have to take an overcrowded bus, that's one thing. But if you're risking other people's lives by going to a crowded beach on spring break, that's another thing. So I think it's a civic duty. It's a civic duty to listen to science and to take things seriously.
Yeah, Maria is asking about even some of the specific things like hanging out with someone who returns from a trip out of state and then quarantines for 2 weeks. Is it fine to see them at all? Should we not see them at all? You know, distance, is it okay to see them but be more than 6 feet apart, but only outdoors, indoors? I mean, there's a lot of questions about what we should or shouldn't be doing.
Well, sometimes in the office when I'm talking to patients, I try to frame things as a continuum, you know. So if we're going to do the absolute 100% safe thing, and what if we did the 95% safe thing? And these are always hard discussions, you know, even when it's not related to COVID. It depends on the situation. So anytime you're hanging out with someone who's quarantined for 2 weeks, you know, maybe they got out of quarantine that morning and they went to the store, and then they hung out over at their parents' house, and then they came to your house, you know. So you're widening the circle when stuff like that happens. I mean, let's talk about 100% safety. 100% is that you wouldn't hang out with that person at all, and you wouldn't leave your house. I mean, there's, you know, you get together with 8 people who are all 6 feet apart. There's no way that people aren't getting closer than 6 feet. That's just not how our bodies move in the world. So, you know, again, if you can be as ultra cautious as you can, and then get to 99% safety and maybe sit outside with someone 6 feet apart, I think that's okay. But if I were giving hardcore 100% advice, I'd say don't hang out with anybody. Does that help? Not at all, right?
Yeah, I mean, the problem is that it's almost impossible to self-quarantine. If you're in China and you've got like a drone flying above you and they're monitoring your cell phone and there's like a police officer standing outside your door, that's one thing. But, you know, self-quarantining here, if you're actually in a house by yourself and no one comes into your house and you're there for 2 weeks, yeah, that's good. But most people, especially people on this call, are living with other people, and they're doing things like going to the grocery store. You know, you walk through the grocery store. Could you have something on your shoes that then is on your dog's paws and then it licks their paws, and then you pet your dog or kiss your dog? Can you, you know, have someone that like is touching a doorknob? Or, I mean, there's a million things, a million opportunities for transmission. Now, that being said, this concept of this R naught, the R with a little O, and the transmissibility, is that we have in Ohio significantly decreased the transmission because of really nice foresight from Mike DeWine and Amy Acton, a Bexley resident actually. And you know, the her husband, Eric Acton, one of our teachers in Bexley schools, of course. So, I mean, they've done a fantastic job, really tons of foresight with being able to get our schools closed in Ohio, the very first state to do that. So really super congratulate them on that. But I mean, I would say that even though you're not 100%, if you do have someone that does not have symptoms and you stay 6 or maybe even to be safe 8 or 10 feet away from that person, and I see people walking around Bexley, 6 feet apart. One's on the sidewalk, one's in the street, which maybe is even more dangerous than having COVID, but hard to say. But people are, if you can actually stay apart from a person, not touch the same, glasses or anything like that, that should be safe. I mean, that should be safe. I'm not encouraging people to do that. But what we see sometimes, and Beth actually had a picture of people, playing basketball together, and, people who were together, but not really quite 6 feet apart. Or you think of anybody when they breathe out in the winter, when it's super cold out and you can see their breath. Well, that breath goes 4 to 6 feet away. And then if you breathe that in, I mean, that's an opportunity for transmission. So we can't see that on a nice 70-degree day like today, but, staying far apart from a person should be safe. But like Beth is saying, it's super hard to do that. If you're vigilant and 100% vigilant, then that should be okay to do. But the safest thing is probably just to stay apart.
So we have a little bit of time left, and I know Beth has to run. Beth has work actually coming up shortly. So if you have particular questions for Beth, if you want to type those in now, that's great. Or any other general questions, because we'll probably wrap this up in 5 or 10 minutes. I think, Mike, one of the things you said earlier that was interesting was the global climate change comment. It made me think a little bit about, we have an acute threat right now. The acute threat is I might get a virus, have a respiratory problem, and die. It's really short-term and immediate. Global climate change is a little different because the threat is long-term. It's like, this may happen, which may cause the polar ice caps to melt, which may cause a rise in the sea levels, which may cause a change in weather, which 30 years from now might cause the destruction of, and it's interesting how rapidly we've been able to mobilize in the face of this really imminent pending threat, and how difficult it is for us to mobilize, even make small changes like change what vehicles we drive or set our temperatures different in our houses, small changes that are much less onerous than the ones we're making in response to this virus for a threat that seems more distant and far away. And I know there's obviously a psychology in that an immediate threat is much more pressing and will respond drastically. But that's been something I've been thinking about that I think is kind of interesting as human behavior and what we're able to change and what we struggle to change.
Yeah, I read something just maybe 2 weeks ago that they found a Neanderthal person with a healed femur. So that's the big bone going from your hip between your knee. And the thought is that a person that had a broken femur wasn't able to walk because that's such a big bone and they couldn't get around. They couldn't care for themselves. They would no way they'd be able to live if not for other people helping them. And so it was a really excellent demonstration that even so long ago, humans cared for each other. And in these days, we are doing that in this acute situation. But like you're saying, when it's a little bit less clear, when it's a little bit more nebulous, when it's a little bit further out timeline-wise, and for the folks on the call that don't know this, both Steve and I were economics majors in college. And so we've thought a lot about how our own behavior affects the group and things like pollution, et cetera. But it's really difficult when you're living in a village in Nepal and it's like super cold and there's like one tree left in the village. And if you chop down that tree, you're going to be warm for a couple of nights because you can be able to burn the wood in your stove. But in the end, long-term wise, it's going to be worse for everybody, which is why, I mean, my thought is that you need a strong amount of leadership with something like this. You need a concerted effort to say, everyone needs a social quarantine. It's like if you close all the windows in your house, except for you just leave one open when it's 20 below zero, it doesn't really help that much. It's better than maybe all the windows being open, but you need leadership to be able to say, and in a timely manner, that this is important, that we all get on the same page and that we all do the same thing. And if you don't have that, it's going to be a little bit like a leaky faucet, or just like leaving one window open when it's 20 below zero.
Yeah. Beth, it's, maybe as we wrap up, it's interesting that like public health has become a conversation. I think, public health was something we never thought about so much. And all of a sudden we're thinking about this, and people like Amy Acton, who was working, and we've had people who are public health directors for a long time, are suddenly like celebrities. And I wonder what that's like to think about how you know, as someone who's worked in the AIDS field and whatever, how public health has taken a new role in people's thoughts and in the national conversation.
So it's interesting because where I work and the kind of work I do, we're always in conversation with public health officials. We treat a lot of monitored diseases, STDs, HIV, hepatitis. And so public health is sort of in my orbit all the time. And they work so hard. They're soldiers, you know, like when they're tracking diseases, they call, they mail, they go knock on people's doors. So they're great detectives and scientists, psychologists, all wrapped into one. So public health is an amazing career. And if anyone was interested in talking more about that, I'd love to, because I think not to be all doomsday, but as COVID changes, as global warming happens, public health is going to be a career that's going to be busy and probably stocked with lots of interesting surprises. I know at Ohio State, they have a dual program where you get your MD and Master's in Public Health simultaneously, and then you graduate and you can be the next Amy Acton. So it's a great career. You don't always have to be an MD either. I mean, you can be an epidemiologist or get your PhD, but there's so much to do with that. And the truth is they've always been around. They've been around forever, but right now we're just seeing them on TV.
Right. And, you know, as we'll take a couple more minutes in our conversation, but for the attendees, first of all, thank you all for being a part of this. I'm glad that you were here to listen to this conversation. If you're so inclined, if you're a participant, I mean, if you're an attendee, if you want to type an appreciation in the, I see Colette just offered a thank you, but if others want to thank Mike or Beth for anything in particular they said or something that's made you thought about, I know sometimes when you're a presenter on one of these, you're talking out to the world, but you don't know how it's being received or heard. So if attendees would be so kind, if you're interested, to just share a little something that was interesting to you, something that you learned, something that you appreciated about this conversation with Mike and Beth, go ahead and take that in now. In the meanwhile, you know, looking forward, wow, I mean, what do you see for the kind of the future of our like social world? Are we going to get back out there? I mean, you know, are we going to be able to hang out with each other again?
I mean, I can chime in. Yes, yeah, we're going to get back to normal. We are, and it's going to take a while, though. I think this is going to change our psychology, though. I think we're really going to be so careful about how we interact with people heading forward. You know, I feel for the generation now in high school, college, like I feel like this is going to change how you operate, and maybe that won't become evident to you even until you look back on it. So I think it's tragic on so many levels, but for the younger people, it's just hard, because I think that this is going to shape how you be a human moving forward. And that's hard, but I think we're going to get back to normal. I have such a great power of belief in immunizations. They changed everything for all of us. We don't even know how much they changed our health from a public health perspective, and we're going to get that immunization. And I think it's going to be such a great, you know, you can see pictures of people getting the first polio immunizations and all these parents cheering. I mean, that changed the world for them. It's going to change how we operate also.
Yeah,
I completely agree. I completely agree. I mean, you think of the Spanish flu epidemic back in 1918, that was worse than what we're doing now. And yet 2 months ago, we went to musical concerts and political rallies and that kind of stuff. So we will return to normalcy. Things probably will be somewhat different, and that's perfectly fine. I've never really enjoyed shaking hands with people in the first place. And Anthony yesterday said, we probably won't be shaking hands with people in the future. I was like, I'm totally cool with that. That does not change anything for me at all. However, I feel like Beth also, you know, we need to use science. And if I could just put a quick plug in for the vaccination support that Beth gave right there, you know, if you look back in time with, you know, typhoid and tetanus and diphtheria and measles, I mean, smallpox, these were horrible diseases and completely devastating, horrible ways to die. And we don't think about those things now at all because of vaccinations. And so hopefully we're going to get this sooner rather than later. But when we do, we will continue to have these vaccinations. And if we are living in this big, petri dish with like 7 billion people, we're going to have to change our behavior. And one of those ways is going to be with smart living, but also with making sure that we all stay safe with yearly vaccinations for this type of thing. So I completely agree, Beth. I think we're going to return to normal and really good times. I mean, look, we're only like a month into this thing here, so we can do it. We can do it. It's not that hard. So
hey, Steve and everybody. Sorry, I got to run.
Thank you, Beth.
All right, thank you. Bye-bye.
Just by way of wrapping up, I think Mike and Beth brought a lot of science perspective to this conversation, and they are scientists and trained in science. My background is more in the social sciences and in economics and psychology and history. But I leave you just thinking, there is a lot of interesting historical perspective we can gain from this experience. I was reading today that the 1918 influenza killed between 50 and 100 million people. 50 and 100 million people. I mean, the death rate now from coronavirus is what, 140,000. So imagine 50 million or 100 million people. And so I think even things like smallpox or polio or some of the things you bring up, I think hearing this conversation makes us think about history in a new way and recognizing that these people have lived through a lot of things like this, and we're having our experience now. Mike, I want to thank you very much. And obviously I'll thank Beth again in person or in some social distanced way. You attended. Thank you. I appreciate you being on the call. I hope it was meaningful and interesting for you. Thank you for all the nice comments you put in the chat so that Mike and Beth can read and recognize that their work was important today and meaningful. So good luck to you all. Keep your social distance, and hopefully we'll be back with some more interesting webinars for you in the future. Take care, everybody.
Thanks, guys.